Greetings from Boston. I'd like to thank the Academy for asking me to present today on myocardial protection. I have often been asked to present on the topic of cardioplegia, but I prefer to broaden the discussion just a little bit since induced ventricular fibrillation is an important component of our practice here in Boston. And before we dive in, please note that I have no disclosures other than the fact that I do reference my textbook in this talk, but I make no money off of my book. All profits are donated to a charity that is very important to my wife and I. So today, my goal is not only to discuss myocardial protection, but to also share with you some interesting facts and anecdotes based on my 24 years at Boston Children's Hospital. The first anecdote that I would like to point out is that the original JECT article that Dr. Del Nido and I published was classified as a guest editorial. Not exactly what you would expect for an original article. In fact, the first article was actually published in India. Dr. Del Nido asked me to write an article about our experience with cardioplegia for a group there, and we ended up collaborating on it. Then, with the help of Bob Groom, who was at the time editor-in-chief of JECT, we published the article in JECT to allow others to access it on PubMed. I believe the original Indian Journal of Extracorporeal Technology, or IJECT article, is now open access after registering on their site, but back in 2012, that was not the case. This was an important accommodation by JECT, and as you can see from the ResearchGate data, the article has 9,000 reads just on their platform and 180 citations. This highlights that there was an obvious need to help get information out there regarding this form of myocardial protection. Many of you may be familiar with the fact that Del Nido cardioplegia, the one we all know and that most of us love, was originally developed in Pittsburgh for use in pediatric heart surgery. The immature heart is structurally and physiologically different than mature myocardium, and the development team leveraged that knowledge to design a new formula. This recipe was brought to Boston by Dr. Del Nido in 1994, and by 2004, it was our sole cardioplegia strategy. And it was different in that it was a 1-to-4 mix used in a primarily single-dose fashion within a recirculating system that was cooled by ice. And it was just very simple and effective. So what's in it? For starters, the formula is to add the ingredients shown here in the middle of the screen to a 1-liter bag of P-Lite. Simple enough, but anecdotally, a 1-liter bag of P-Lite isn't really a liter. Well, this may not be, but this is because each liter bag typically has a 10 to 15% overfill as an industry standard. And this may not be clinically relevant as far as we know, but it is important to understand for in-house production, particularly in an automated system. The original formula literally had the perfusion team grab a bag of P-Lite off the shelf and in the pump room add each ingredient. We would make our own cardioplegia supply every day. Now that was back in the 90s and early 2000s. Now there are commercially available options as well as protocols for the pharmacy team to produce the cardioplegia under a hood or in an automated system, which undoubtedly has made the process safer and more precise. Just to note, we published a report in 2017 describing our production, quality control processes, and also stability testing, which, by the way, shows stability up to 1 month when stored in a refrigerator at 4 degrees Celsius. Now, I don't think I need to necessarily describe the importance of each component with this audience, but I will point out that the intracellular calcium control is a major tenet of Del Nido cardioplegia. And the sodium channel blockade with lidocaine and physiologic calcium channel blockade with magnesium are both key for this. It is also important to note that the ingredients may vary a little bit based on available concentrations. For example, we've used 20% mannitol as well as 25%. Either way, the final concentrations end up being the same. Now, for our international users, P-Lite is not always available as a base solution, but there is very commonly a balanced electrolyte solution in the hospital which can be used. And an example of this is shown in the upper right-hand corner of this slide. This was a solution that I found on a trip to Argentina several years ago. Additionally, there are reports published a nod of people trying other base solutions for del nido cardioplegia, such as a group out of Thailand who used LR as a base solution. Their report in adult CABG patients showed LR to be a viable option, but there's really limited supporting data outside of their work. And you'll note that a hallmark of del nido cardioplegia is having a low calcium value. The only calcium in the final mix comes from the patient blood component. LR itself has calcium in it, so I would certainly use caution in considering LR as a base solution. Ultimately, as we will see with most published studies, outcomes have been so favorable with del nido cardioplegia that people will do what it takes to get a reasonably similar product for their patient population. All right, so now that we know what's in it, what does the circuit look like? Our circuit is very simple, even though it may not appear to be on this slide here. The crystalloid component is added to a recirculation bag through a 0.2 micron filter, which is shown in the upper left here. This volume runs to a mini pump head and is pumped through a coil submerged in an ice bath, then onto a bubble trap with a screen filter, which of course would be oriented vertically in a heart-lung machine, and then onto table lines. On the right here is a close-up of the table lines. The top picture shows a clamp on the return limb, and this is what it looks like at the surgical field during delivery. The bottom shows the outlet limb clamped as it would be during recirculation. This keeps the cardioplegia cold and well mixed in this minimal dead space system, which is particularly important for smaller patients. And here you can see the recirculation bag has the 20% blood component added, and the final mix is ready for delivery. The dose we use most often is 20 mLs per kilo, up to a max of 1 liter for the arresting dose. We may give smaller doses for short procedures of 10 per kilo. We commonly give a single dose for cross-clamp periods of 2 to 3 hours, but our surgeons will redose if there are any concerns with myocardial protection, particularly in older patients or if there's evidence of electrical activity. In regards to delivery, we do not measure root pressure, so we tend to go by our system pressure and, of course, the surgeon's palpation of the aortic root. Our system pressure is commonly 100 to 200 millimeters of mercury. If you start delivery at about 10 mLs per kilo per minute, up to a max of 250 mLs per minute, you are usually in a good spot to dial in the flow up or down as needed. And it is worth noting that slower delivery rates help prevent wall stress in the coronaries, as well as help cool the heart overall. And certainly you don't want to just slam the cardioplegia in. All right, so how do we calculate the patient whole blood component to add once we are established on bypass? Well, in a 1-to-4 mix, there are 5 total components. So as shown in step 1, if you divide the dose volume and circuit volume and minimum operating level in your cardioplegia circuit by 5, you get the required blood component volume. Then, moving on to step 2, if you take the 20 ml per kilo dose volume plus the minimum operating level, which is 25 in this example, and subtract the blood needed, you get the crystalloid volume, which should be recirculating in the system before you go on bypass. Then, as shown in step 3, you go on bypass, and with the crystalloid del nido component recirculating, you add the blood after establishing bypass. After delivery, you will be left with just the minimum operating volume in the system. So it sounds complicated, but after doing it a few times, it really isn't that hard to do the math. Our perfusion practice actually includes this calculation as part of a spreadsheet that we prepare for every case, and it makes it that much easier. Now on the right-hand side here, it shows an example for a 6-kilo baby, just for reference. I won't go through the specifics as they're just as I described, but feel free to screenshot this if you feel like doing the calculations by hand. All right, so we've done the overview and the circuit dose and delivery. Let's look at some studies. Now, I mentioned earlier that there have been 180 citations of the original 2012 paper that Dr. Del Nido and I wrote. And there certainly isn't enough time to go over all of those papers, but I will highlight some papers I consider key publications. I consider the first three papers here as important because they came out before our 2012 article. There's not a lot of literature available on Del Nido cardioplegia, at least in its present form, back in the early 2000s. A group in Nova Scotia who had an attending cardiac surgeon that did a fellowship with us published two reports. Their 2009 paper compared their standard cardioplegia formula to Del Nido in pediatric patients, and they found lower troponin T levels at ICU admission and 24 hours post-op in the Del Nido group. Their 2011 paper was an animal study looking at Del Nido cardioplegia in adult rat cardiomyocytes. They observed lower intracellular calcium accumulation as well as less frequent activity as compared to, once again, their standard formula. And the third publication that I think is key was from Kevin Charette and his group at Columbia in New York City back when Kevin was there. They did a retrospective review of cases performed by an attending that had trained and worked at Boston Children's, Dr. Emil Basha. They found that in propensity-matched pediatric patients with a cross-clamp time greater than 90 minutes, the Del Nido group had a lower incidence of hyperglycemia with no detectable differences in outcomes. But as we will see in subsequent reports, there are at least subjective advantages beyond better control of glucose, such as only having to give cardioplegia once for most patients. So after those early reports, in our 2012 paper, numerous publications came out in the pediatric literature. Most publications found Del Nido cardioplegia to be advantageous for a variety of reasons, including lower inotrope scores and lower cardiac enzymes, a higher incidence of spontaneous defibrillation, a lower incidence of hyperglycemia, like the Charette paper, and even a lower incidence of blood transfusions. Niji et al. Published a prospective randomized controlled trial in TED patients, which included some long-term follow-up, which is why I chose to list it here. They showed lower inotrope scores in the Del Nido group, but no differences in outcomes at 3 and 6 months post-op. That was an interesting paper, but it was unfortunate that those authors plagiarized the original article from Dr. Del Nido and I without any reference to our work. And it was also unfortunate that it took the editor of Perfusion and the publisher of that journal a very long time to correct the issue. So if you have free time on your hands, you can go on a scavenger hunt and you can read that paper and look for the 100 words that were lifted from my original paper, as well as a couple more passages that were borrowed. I also think it's worth noting the Talwar paper from 2019, since those authors looked at myocardium under an electron microscope. They found that the HTK cardioplegia group had more myocardial edema and myofibrillar disarray than the Del Nido group, which is certainly an interesting finding. And finally, it's worth reflecting on the Drury paper, also from 2019, which properly pointed out that the current pediatric literature for Del Nido cardioplegia is lacking due to small sample sizes, heterogeneous populations, and a lack of consistent long-term follow-up. So essentially, a lot more work needs to be done, and I really don't think anyone would disagree with that. And as a courtesy, here are the papers I cited in the previous slides. All right, so now let's look at the adult literature. This is important even at Boston Children's, since we have a robust practice with a considerable number of adult congenital heart surgery patients who may also have acquired disease. But in fairness, most of the adult literature is looking at Del Nido cardioplegia in CABG and valve patients, not necessarily adult congenital patients. Again, this is just a sampling of the literature. I chose the first two papers since they were early reports for the use of Del Nido cardioplegia in adults. In 2014, Yerbach and the group at Columbia once again showed that Del Nido cardioplegia could safely be used in acute MI patients and that the Del Nido group had shorter cross-clamp times. Stephanie Mick's group at the Cleveland Clinic showed in 2015 that the Del Nido cardioplegia could be used in valve surgeries as well, but they pointed out that more work needed to be done. And other authors later published findings in adults which essentially mimic the pediatric literature with reports of lower glucose levels, shorter bypass and cross-clamp times, shorter ICU and hospital stays, more favorable cardiac enzymes, and once again, a higher incidence of a patient regaining a rhythm spontaneously after cross-clamp removal, which I think intuitively may indicate superiority and better myocardial protection. But as with the pediatric literature, ironclad data is still elusive, and universal use in all adult surgeries is still cautioned. Don Lukoski and Dave Fitzgerald published a great review of 26,000 patients from the PERFORM registry. They divided patients into an early period running 2014 to 2015 and a late period running 2017 to 2018. And they found that the Del Nido group, relative to other formulas, had shorter bypass and cross-clamp times, and that the difference here further improved in the late period. There were no differences in outcomes overall, including morbidity and mortality, which is great. This was good news for the Del Nido cardioplegia group, or for Del Nido cardioplegia being adopted in adult practice. But once again, as stated previously, more studies are needed. I guess you can say there's always more work to be done. And here are the adult references I used for this presentation. All right, so we've reviewed the left side of this presentation. Let's move on to the next section, which is, why does it work? Well, as mentioned earlier, Del Nido cardioplegia includes a low calcium load, and there is potent management of intracellular calcium accumulation, primarily with the lidocaine and magnesium. Del Nido cardioplegia also has a low viscosity, which may importantly aid in homogeneous myocardial delivery. And of course, I believe a major reason why Del Nido cardioplegia works so well is that the lidocaine is a potent inhibitor of electrical activity during the arrest period. It just sits in the heart during the cross-clamp period, and it prevents activity and also promotes spontaneous defibrillation once the clamp is taken off. So in summary, unique aspects of Del Nido cardioplegia are that it helps control intracellular calcium accumulation, it potently inhibits electrical activity and thus mechanical activity, and these myocardial protective properties promote the resumption of a normal rhythm in most patients. The stuff just works. I've yet to see a visitor in our operating rooms watching a case with Del Nido cardioplegia and use for a 2 or 3 hour cross-clamp period. I've yet to see them not be amazed when the heart starts beating after taking the clamp off, like almost immediately, and the heart functions well enough to separate from bypass in 10 or 20 minutes after a big case. And of course, I still enjoy seeing that myself. And so that brings us to the comments section. I have some final thoughts to share with you. First, this is a question I've gotten quite a bit over the years, which is, can I just make it? Yes, you can make your own cardioplegia. I mentioned the paper on the left here earlier. Ideally, in-house production is manually done under a hood or in an automated system in the pharmacy. There really should be quality control checks in place in preparing Del Nido cardioplegia, as with any cardioplegia. And I wanted to be clear on that. We are, after all, perfusing someone's heart with cardioplegia. It should be prepared as safely as possible. Secondly, I'd like to address a question I've received over the years, which is, can I just give the stuff every 20 minutes? Some centers have been very concerned about not cooling the heart down every 20 minutes and washing the heart out. But the Del Nido formula wasn't designed to be given every 20 minutes. And I know that centers that have tried giving it more frequently have complained that the heart takes a while to wake up afterwards. So it certainly isn't recommended. But I do know that some centers have gone to empiric dosing at some interval, like every hour, and they seem to be doing fine and giving like 10 per kilo as a dose every hour. The third question to address here is, can I just add the blood component before bypass so that I don't have to worry about it once on pump? This, of course, is for a recirculating cardioplegia system. And this is probably the most important question here, and I'll tell you why. I'll share a story with you. I was consulted on a case years ago from another center. I was asked if I could help figure out why a patient's heart did not come back after the clamp came off. We went through everything, including the components, the ratios, the circuit, the temperature, the delivery, the storage, everything. Then I asked where the blood portion came from, and I was told that they used bank blood directly. Of course, this was very unfortunate. Bank blood has citrate, which everyone knows binds calcium. Well, when you add citrate to a low or zero calcium solution, the calcium level will be zero. This leads to the calcium paradox when the myocardium is given cardioplegia and then reperfused. The cardioplegia delivery itself weakens the ultrastructure of the myofibrils by stripping off calcium. Then, during reperfusion, when the calcium level is restored and the heart contracts, the weakened ultrastructure falls apart and there is no coming back. Stone heart results. So if there's one thing you remember from this talk, it is this: use oxygenated patient whole blood once you are established on bypass for the blood component of del nido cardioplegia. But I will say that in certain situations, you can blood prime a circuit with cells and FFP, do pre-bypass ultrafiltration of that, get a nice balanced electrolyte profile in that prime, and you can use that for the blood component. And we've considered this option for sickle cell patients and those with cold agglutinins, since we wouldn't want those processes taking place in the cold cardioplegia solution. So those are the exceptions. And finally, the fourth item here is really just a comment. There was an interesting publication by Mukdad et al., which equated single-dose del nido cardioplegia with lower gaseous microembolide loads relative to a standard multi-dose cardioplegia practice. And I had an opportunity to provide an editorial review of this paper, and I think their findings are certainly worth further investigating as people look at GME and neurologic outcomes. So again, just a very interesting paper I thought worth mentioning. And so that is del nido cardioplegia for myocardial protection. And the other topic for this presentation is induced ventricular fibrillation. Now, we use induced ventricular fibrillation in Boston alone or as an adjunct to giving cardioplegia. Some of our surgeons use it for short anticipated cross-clamp times or during the assessment phase of intracardiac repair, such as during the double switch procedure, or when just simply placing a cross-clamp would be difficult, just to name some of the options or times when we use this. We use a fibrillator box to induce fibrillation, and there are additional considerations for the perfusionist during the fibrillation period. First, here is the equipment. On the far left is the Synco Model 2039 fibrillator box that we currently use. This is a plug-in model, and we like it very much since you don't have to worry about batteries. You just plug it in and go. We've had success with this box for many years now. Another option is the Peter Schiff Model 310C, which we also used. It's a great device, but it does have internal batteries, and you don't always know when those are going to fail, even if you test it monthly. So frankly, that's why we moved to a plug-in version. But we still do use the Schiff fibrillator pads shown on the right. They come in adult and pediatric sizes. You can actually cut the silicone there too to get better placement around the heart. Now, one of our surgeons prefers to simply use pacing wires in the heart for induced fibrillation, and the pacing wires can attach to the Synco box on the left here. So that's another option. All right, so that's the equipment. Let's look at two charts pertinent to energy usage during fibrillation. Now, these charts are important to understand because occasionally an astute perfusion student or surgical fellow will correctly point out that a fibrillating heart uses more energy than a beating heart, which is true in most settings, but not in the operating room. So let's take a look at the chart on the left to start, from Jessen et al. This is an animal model, but it's useful nonetheless. A key component to successful use of induced fibrillation is that the heart is empty. A full or distended fibrillating heart is certainly a bad thing. An empty fibrillating heart does use more energy than an empty beating heart, but as shown in the chart here on the left, it is considerably less than the warm beating heart. The heart must be decompressed, and very often with induced fibrillation, the heart is open, so that's really not an issue, but it is a consideration. So now let's look at the chart on the right from none other than Buckberg himself. This animal model data helps point out another important consideration for use of induced fibrillation, which is that some degree of hypothermia is always used. At 37 degrees, fibrillation increases myocardial oxygen consumption relative to the beating heart. But at hypothermia, a fibrillating heart has lower oxygen consumption relative to an empty beating heart. Therefore, induced fibrillation is never done at 37 degrees. You must cool the heart when doing induced ventricular fibrillation. All right, lastly, let's, what are the considerations for the perfusionist during induced fibrillation? There's not a ton of available literature on this topic or even in textbooks, so I put a small section in my book based on our experience in Boston. In order to avoid the risk of subendocardial necrosis due to the heart not beating and assisting with coronary perfusion, it is advisable to run your target blood pressure a little higher than normal and to make sure you have a reasonable hematocrit during induced fibrillation. And I will also add that particularly for pediatric centers, the volume holdup in your suckers during induced fibrillation may require you to add volume to maintain overall pump flows. And finally, consistent with the charts we just reviewed, we generally do not rewarm until after the induced fibrillation period is over, since rewarming increases myocardial metabolic demands and it increases the risk of converting to a spontaneous rhythm, particularly if the fib pads are not in place or if they have poor contact with the myocardium. And with that, we have covered myocardial protection using both del nido cardiplegia and the induced ventricular fibrillation methods. So thanks again to the Academy for having me today, and thank you for listening to this presentation. I'm happy to answer questions during the discussion period. Thank you very much.